So Burdine, the parent compound, is a compound called 4-AP. And it's one of the first drugs that is now available. It's unique. It's a first of its kind available on the market. And it has been shown in subjects with neurologic problems to improve function. And that's probably related to nerve conduction. And so we've seen improvements in demyelinating disorders like multiple sclerosis. And this is how Burdine works. So if you go at the left-hand side of the slide, your left-hand slide, you can see this is just a picture of what a nerve or a nerve tract might look like. And those little sort of sausage-looking things around the nerve fiber are called myelin. And that's the insulation of a nerve. So a nerve is very much like an electrical wire. So you can see that part in the middle without the insulation. Well, that's a naked nerve, okay? So normally what will happen when a nerve is well myelinated, that signal travels down the nerve nice and strong and nice and fast. So you can see in the little box below we have that red, nice, strong nerve signal. So that's going to jump along to the next nerve and send the signal, whether that's for walking or whether that's related to fatigue or vision or memory. That's going to send the signal nice and fast. If we have a nerve that's demyelinated, which you'll see here, then that current, the strength of that nerve signal, that current leaks out. So you lose some of the electrical strength of that signal. And as that happens, the signal goes down. So you see that blue signal. And if the signal gets small enough, it can't get through to the next part of the pathway to get the signal through. So if there's signal failure, that could result in weakness, that could result in poor bladder control, that could result in fatigue, or a number of different symptoms that people experience with their MS. So what Burdine does, these little sort of white diamonds on the slide, on that naked part of the nerve, it blocks potassium channels, and potassium channels is where that current is leaking out. And so in doing that, it maintains that strength of that nerve impulse. So if we can keep that nerve impulse strong, it has a better chance of the proper signal getting through and getting down the line. So if that's happening, that could improve an MS symptom. Now, the studies that have been done on Burdine, the major ones that have resulted in the release of the medication, have been done with walking as the main outcome of the study. So our center here in Halifax, we participated in two trials, which were called MSF 203 and 204. And those were phase 3 trials. So that's the last phase of research before they decide if a drug is going to go onto the market. So across the world, there were 301 patients in the first trial and 237 in the second, and 33 MS centers across US and Canada. And there were centers in Europe as well involved in the studies. It was open to all patients with all 4 types of MS, and they were permitted to stay on all their existing medications, including their disease-modifying drugs. You had to be able to walk a 25-foot walk course in a certain amount of time to go in the trial. So the primary outcome was the time it took you to walk the 25-foot walk course. And then there was a number of secondary outcomes that they looked at. A subjective scale around walking called the MSWS-12, the global impression of the subject, if they improved or not, the global impression of the clinician or the researcher, if they improved or not, lower extremity muscle strength, and as well as spasticity. And this was a blinded study. So it was a placebo control. So in the first study, about 2/3, or it was a 3-to-1, every 4 patients, 3 got the drug and 1 got a placebo, so a sugar pill. And the patient or the person in the trial didn't know that, nor did the research investigator. So when you were evaluating the outcome, you didn't know if they were on a medication or not. In the second trial, it was 50-50. So half the people got medication and half the people got a placebo or a sugar pill. So what we saw in the studies, this was a result from the first study, and what you'll see here on the left-hand side are people who got placebo, and on the right-hand side, the people who got the actual medication or the Burdine. So about 35% of the time, people who were taking Burdine walked faster. And the study had something called a responder criteria. So it wasn't just that one time you walked faster than when you weren't on the drug, but you had to have 4 out of 5 walks on the drug that were faster than your fastest time of the times that you were tested when you were off the drug. So it was pretty stringent criteria. You had to be consistently walking better. So about a third of the patients did that when they were on the drug. and only about 8% of people on placebo. So sometimes placebo will rev you up, sort of give you that sense of I'm going to do better, and that will help you walk faster. So we saw that in about 8.3% of placebo. In the second study, actually, almost 43% of the people on the drug met that stringent criteria for walking faster, and only 9.3% on placebo. So you can see, it's a bit oversimplified. So for about every 3 people that were going on this drug, you would get 1 or 2 people that would have a response to it related to walking. Okay, so this is just a video, and this isn't one of our patients, but it's a video I've had permission to show. And this shows a patient on the left side in the red is with her off of the drug, and on the right side she's on the drug. So you can see actually by the time she gets down to the end and turned around off the drug, she's already pretty much back and finished the course when she's taking the drug. Okay. And you can see also though, she hasn't thrown away her crutches. She's still needing her adaptive aids. But you can see that her walking is just a little bit smoother, it's taking a lot less energy, and she's going faster. So the average increase in walking speed was about 25%, and the perceived change in mobility was found meaningful. So people who were walking faster also reported that they felt better. They felt like they were doing better on the drug. And the important thing about this medication is that the benefits were independent of the MS course type. So I know a lot of people come into my clinic and they're frustrated because all the disease-modifying drugs seem to be only if you have relapsing remitting. And if you're not walking anymore, you have secondary progressive, they're not as helpful. And if you're primary progressive, they're not helpful at all. So with this, we had patients with primary progressive, we had secondary progressive, we had the relapsing remitting, and even the relapsing progressive types. And all of those, we saw individuals in all of those groups have individuals that improved on the medication. So this isn't limited to one type of MS, and I think that's really important. And the other thing that we saw on this was that it was independent of your level of walking. So we had people in the trial who were walking very, very slow, even sort of bordering on not being able to walk anymore. And we had other people that were just starting to have walking difficulties, so still doing really well. And those two ends of the spectrum and everything in between, again, we saw individuals that improved. So it wasn't just our fast walkers that walked faster or just the slow walkers. We saw improvements. We saw improvements across the board. So just related to that study as well, so the main outcome in that study that was followed was walking. So when that drug comes out in Canada, that's going to be the main use. But because this drug improves conduction of nerves, there's a lot of potential for it to help with symptoms beyond walking. And that's what the companies and the researchers are dedicated to right now, is understanding other ways that this drug can help. We know patients who have been in our trials who are still taking the medication who aren't even walking anymore, but they might be finding that their bowel control is better, or they might be finding that their fatigue is better. So we're trying to put the research together to get better ideas what other areas that this drug can help. So I think this is an exciting new drug for people with MS, and I think it will have a lot to offer over the next many years. So the other new thing, or newer thing I'm going to talk a little bit about, is botulinum toxin related to mobility. So a lot of people think of botulinum toxin as something that people get for wrinkles, and that's actually something that sort of came along later. The original use for botulinum toxin was for overactive muscles, okay? So, and spasticity is one of those things. And I always joke with my patients, because when we're doing Botox therapy, they always wonder if there's any left over for their wrinkles. Or some of the people that help me in clinic ask the same question. Did you use all that Botox on Mr. Smith today? All right. So spasticity itself is a common symptom of MS, and some of you may experience that. So muscle stiffness, muscle pain can be involved with that. Difficulty moving your muscles. Sometimes the muscles are jumpy and they move, but they do things you don't want them to do. So those are all symptoms of spasticity. And spasticity can affect mobility. It can also interfere with your sleep and your comfort and your transfers and lots of different things. So when it is interfering, we often decide to treat it. And we treat it with all kinds of non-medication things like the exercise and stretching and sometimes bracing and adaptive aids, which we've already talked about, but sometimes we do need medication. And usually spasticity in MS is not just one muscle group, so it's often quite generalized. So we often do start with medications by mouth. But often, despite that, there might be a problem group. So you might have your legs are pretty stiff, but maybe it's your feet just can't get them off the ground, you're catching your toes all the time. Maybe that's the worst muscle group. Or maybe it's your legs pulling together so you can't get them apart. That's the worst muscle group. So when we have local problem groups like that, those are things that we can target with things like botulinum toxin. So this is just a diagram of how botulinum toxin works. So what it actually does is, this is the terminal of the end of a nerve just before it is communicating, or what we call synapsing, with the muscle fiber, okay? And nerves release chemicals that make the muscle fibers contract, and that makes the muscle work. So basically, when botulinum toxin gets into a cell, it prevents those chemicals from getting out that makes the muscle contract. So we don't want to turn the whole muscle off, but Botox we use very specifically in specific areas of the muscle to turn part of the muscle off, to tone down that spasticity, to get the muscles back in balance so they can do their job better. So it's been shown to be safe and efficacious in a lot of neurologic conditions. But there's not a lot of literature on the use in the MS population, and none of the literature so far has specifically assessed walking. So we did that in a small, what we call open label trial. So in this trial we had 6 patients and they all got Botox. And before they got Botox, we looked at their walking speed and their walking endurance, and then we looked at it again after they got Botox. So the blue bars on this graph are before and the red bars are after. So you can see many of these individuals had improvements in their speed. The improvements varied. Some of them had really big, 2-3 times their starting speed on the Botox, and other less significant amount of speed, but these individuals still felt better after the injections. And this is endurance, so we saw something very similar too. So when they had less spasticity to fight against, they were actually walking farther. So this, as I mentioned, is open label, so everybody got the drug and they knew they were getting the drug. So that enters a certain amount of bias into a research study. So now we're just trying to get funding to do this in more of like a placebo-controlled blinded fashion. So we'll have some individuals, they'll all get needles, some will get Botox and some won't. And neither the patient nor the researcher will know if they got the Botox, and then we'll see if we can reproduce similar findings. So this is a video, this patient's near and dear to me. She's no longer with us, but she gave me permission to use this video for teaching and education, and she said if her information could help other people do better with MS, she was really happy about that. So you'll see in the video on the left how stiff her legs are, and she's having quite a lot of trouble moving along there with her walker. That's spasticity. So by injecting some Botox into her lower extremities, we were able to decrease some of that spasticity, and you can see in the second video how much smoother she's walking. So her knees are bending better, she's getting her toes off the floor. So when we talk about energy conservation and fatigue, as Paula talked about earlier and Sue touched on as well, you can see she's burning a lot less energy in that second video. So she's going to walk farther, she's going to walk faster, she's going to get more out of her mobility. So in addition to that walking faster and farther, the individuals in this little study also said they had less pain, they had less clonus, they had less muscle spasm, and they were walking easier.